I wanted to start by saying, hi, I'm Alana Vaz, and I'm working with ARC. I've only been here a year, but spasticity is something that I've been thinking about for a long time. In fact, so I'm a physio from a long time, and I think when I was 12 was the first time I ever, I discovered that my brother had a knot in his calf, and the finals of the state championships were that afternoon. And so I stuck my thumbs in. It seemed to work because he won the race, and becoming a physio was just the most obvious thing after that, especially since some of you also know that when I was 16, my aunt had a car accident and a brain injury. So Arthur, can you mute your computer again?
Sure.
And maybe Bob too, and Sonia.
I don't know how to mute it. There's no control for me to mute. It has to come from you.
Okay. Yep. All right. I've just muted you. Thanks. I don't want to get rid of you. Just I'm going to talk. So when my aunt was in the hospital for about a year, I didn't know the word spasticity. I had no idea what the medications were or what the doctors were talking about. I just understood that my job was to sit on her left-hand side and talk to her from her left because she wasn't turning that way. I would sit there for hours with my little cousins chatting away while I stretched her hand and helped her practice thousands of times the little movements that she could do. So I didn't need to know any of the medical things to know that that was the right thing to do. And then it was just obvious that I was going to do that as my job, which is what I have done. And so I want to talk about spasticity, what it is. I want to talk about it from the point of view of the medical words so that you know what people are saying, but also what is it to you? What causes it? We'll talk about that too. And in thinking about it, my guess is your first questions are, can I make it better? Or could I make it worse with what I do? So as I've said, I asked lots of people. Some people will talk about the sudden jerky movements of spasticity are the worst bit or the main bit. For some, it's the stiff. For some, I think you were beautiful, Sonia, when you said my leg or my arm jumps when I don't want it to, and I can't move it when I do want it to. So it certainly happens when you yawn, or what sometimes can happen when you yawn, or there are other emotions or other movements. And I will say it's not the same as spasms, but exactly what the difference is can just become a technical thing that we don't need to worry about, or we will worry about it right now and talk about it. There's another class of answers that I got. So my sister, her response was that spasticity is a rude word, you can't use it. We used to use it in the playground as an insult, but they changed the Spastic Children's Society. They've changed that now to the Cerebral Palsy Society. It seems that it was a rude word that we couldn't use, but my daughter's response in the same conversation was, why would you use, it's just a medical term, why would you insult someone with that? If someone can't move just the same as I do, that doesn't mean we don't include them in the playground. And I'm hoping that that is a generational change that we have, that perhaps more education, more use of the word, more use of more integration in primary schools and high schools has allowed it to move on, the change from my generation to the next. And okay, let's get into some more specifics. There are certain conditions that are associated with spasticity. Multiple sclerosis, about 40% of people with MS will say that spasticity is a significant problem. In cerebral palsy, CP, most studies would show it's up to 90% of people with CP have spasticity of some sort, which is not surprising given that the brain is still developing with this, along with the spasticity, along with the child growing, the spasticity is also developing and changing. We'll talk about the plasticity in a minute. After stroke, studies show 35% of people might have spasticity, and it has a different path. Traumatic brain injury also has about 30 to 50% of people will have spasticity, and it can vary so much as to whether it's your whole arm or leg or just individual muscles. In spinal cord injury, spasticity is extremely common, although not everybody. And I'm going to say that from my point of view, the quality of the spasticity in a spinal cord injury, especially one which is more complete, where there's less connection with the conscious movements. It's quite a different quality, and perhaps it's more like the sudden movements of their whole body, going from pushing the legs and the body fully straight to bending them back up again, when it doesn't seem that anything has touched them. And it looks much more clearly like a reflex response when it's unopposed like that in a spinal cord injury. So the slide shows HSP, a hereditary spastic paraplegia, which hereditary is genetic, and it is specifically the spasticity that causes that, the definition of your condition. Hypoxic brain injury. So that's just any of the injuries that where there just wasn't enough oxygen to the brain. So drownings or near drownings and cardiac arrests that have been resuscitated. And there are other reasons why you might have a hypoxic brain injury. If that's your case as well, that's also slightly different, because the damage, rather than being relatively focal, as it might be in a stroke, is spread across the whole brain. So there'll be different parts of the brain affected, brings on other challenges with that. And motor neuron disease has a different pathway, but motor neuron disease where the motor neurons are degrading. These are the conditions that can have stroke. There are other conditions that look like sharp, jerky movements, or stiff and uncontrolled movements, or as you might feel for yourself, the fact that I just can't move when I want to move. Let's go to the next slide. Don't want to worry you with all these pictures, but the top row of brains shows the part of the brain that has been damaged in this case. The ones on the left three brains have been injured or damaged, or the cell problem has occurred on the outside part of the brain, the cortex, where most of your thinking happens. And it just goes to show that sometimes if that part of the brain is the muscles all on one side are weaker, or just the muscles on the legs are weaker or aren't getting messages through. And sometimes it can be all across the cortex, and so it can affect all four limbs, so quadriplegia. This just identifies that there is an interruption in the messages. And most of the issue is going to be weakness. Most of the issue is going to be messages not getting through motor-wise, and messages not coming back up sensation-wise. Spasticity doesn't occur in all of these cases. And I'll just describe the ones on the right. The basal ganglia, damage the basal ganglia. You see the little red part of the brain is further inside, closer to the brain stem and the central part of the brain. And diseases like Parkinson's disease or Huntington's disease or other even vestibular diseases will cause jerky, uncontrolled movements, but I'm going to say not strictly speaking spasticity. So in some cases, the treatment for both is the same, but let's get specific. So this is the textbook definition we learn at uni, and let's talk about it. It's a disorder of the sensory motor system characterized by velocity-dependent increase in the tonic stretch reflexes that everyone has. And so it has exaggerated tendon jerks resulting from excitability of that stretch reflex, which is only one component of the upper motor neuron syndrome. Lots of words. I'll leave it up there so you can read it again if you want to, but I'm going to tell a story. So if you think of the brain as having messages going down to make us move and messages going back up to tell the brain what we feel, spasticity happens when that feedback loop goes wrong. The reflexes that we have that were supposed to keep us safe, like, when you touch a hot stove and there's a local reflex that gets us to bring our hand back. Well, we want that local reflex. That's a good thing. It's a local reflex that suddenly and strongly lifts our hand away from the heat without waiting for the message to go back up to the brain. That local reflex is usually helpful and usually only occurs when there's an urgent need, like the danger from the heat, or indeed the joint being suddenly stretched, like you're about to fall. Your tendon will be suddenly stretched, and it's quite appropriate that we have a reflex that only involves the tendon and the very close spinal nerves in order to have a quick response, so that if it's hot, we move away. If we're falling, we turn on the muscles to help us stand. That the over-exaggerated tendon reflex occurs because for a short time, there's a disruption in the smooth balance of messages to and from the brain. And while the body is trying to sort this out, then there's an excess of this urgent messages going both ways. And in some cases, that excess of urgent messages will result in an exaggerated tendon reflex and then the longer standing spasticity. So there you go with a medical definition and with one story. I've got lots of other stories. So like this one, when we're awake, the brain is sending positive or excitatory messages all the time so that we're ready for action. It wouldn't make sense for the brain to wait until we decide we need to lift our hand up to pick up a cup, for it to then send the startup, like a Windows machine, a computer machine might just send the startup messages then, but our brain sends those positive messages all the time so that our hand is just below the threshold for movement. And that's what we want, those excitatory messages. In our brain, we also have some arcs and some complicated pathways that have excitatory and inhibitory, and they keep themselves in check and maintaining the balance. The brain maintains that balance so that we're not always moving. And let's stay on that concept. I think we all know when we get a tick in our muscle, like a twitch in the eyelid, or even just a slight tremor in our hand when we're ready for something, like just before a running race, you have that, perhaps you have more excitatory than inhibitory and the balance is out of whack for a short period of time. I'm not making light of that, because spasticity occurs when that balance is not restored and the reflex arc therefore it adapts to be hyperreflexic and hyperreactive. I'm hoping that makes sense, that everyone already knows that whoever you've been working with has already been telling you, and making the shift from the medical terms to the logical, to the stories that we all understand. Just a few more things to make sure that we're all talking about the same thing. So spasticity is specifically that sudden jerky movement, which is when the tendon reflex is hyperactive. Hypertonia is an umbrella term to suggest that all of the muscles are right next to that threshold of activity all the time. Well, sorry, whichever muscle is hypertonic is just at that threshold all the time. Lots of reasons why that might be. And spasticity might indeed be one of them, and it might be part of it. But it might also be on its own. A spastic muscle could be just an individual muscle, and hypertonia can just be on its own without actually having any of the reflexes being hypertonic. Clonus is when the spasticity, as you'll see in the videos, gets into that reflex arc and just keeps going. And if you've got that, you've already worked out ways of stopping it. You stop it by either stretching the tendon or the muscle more, or by changing the position of your arm, your leg, whichever one is in clonus. I rely on you guys to find your own, or to tell me what it is that is the best method for you to get rid of the clonus or to tone it down. The other half of the slide talks about dystonia, rigidity, tremor. They are all uncontrolled movements that you can't consciously stop or can't consciously even start, I guess, associated with issues of the basal ganglia. So most often with rigidity and tremor and dystonia with Parkinson's and other diseases, also with MND, and of course with a brain injury or a hypoxic injury where parts all the way across the brain have been compromised at some point or disrupted. Might have just one of these or all of these. Some of these might be the most disturbing to you, and that's what you want to work on and think about and ask questions about. For some of you, though, for the majority of people, I would like to say that if you have a problem with spasticity, let's address that. But most likely the biggest problem, and the problem that that we will focus on, is the weakness, just the not getting the correct messages down physio and exercise can increase the strength of muscles that are still there, muscles that you are able to move. We can increase the strength. We can increase the stretch so that you can get into the right position to do the movement that you want. We can then need to train exactly the finesse so that you're not just in the right position, stretched out, you're not just strong enough, but you've also got the particular coordination that's required to get the movement, to motor retraining, to get the activity exactly the movement that you want. So I've talked about what causes spasticity, but now I want to talk about what triggers it. Again, I think if you're sitting here in this webinar, I'm assuming that you already have someone that you can, yourself or someone you're sitting next to who you can think about. And so I want you to think to yourself, what is the trigger? Is the trigger just when you're trying to move one muscle and then this movement happens? Is it just when you're in a particular position? And isn't that right? It is. If you're laughing or crying or yawning, I'm going to say that absolutely triggers these reflex responses. I'm not going to say that they are in my understanding of it, it's never the laughing or the crying or the yawning that has caused the as in, it's not caused the change in the reflex arc. It's never the thing that has been the fundamental problem. But once the spasticity is established in your tendons, in that tendon Golgi organ, once the spasticity is part of the motor pathway, then laughing, crying, yawning, and for someone with a spinal cord injury, just moving, just being moved. But the sensitivity to touch and surfaces, I wanted to tell a story about a brilliant lady we worked with 20 years ago, who she had spasticity in her left leg, but only when her left foot was touched. So if it was touched when she was lying down, her whole leg would pull in, just like as if she'd touched something hot. Not a very useful response when she was standing, because as soon as her left foot touched the ground, she would jerk suddenly, and it was her whole leg lifted up. Well, that means she's standing on one leg. So this is the story that I want to tell you, is that her spasticity was very strong, very sudden, and very overwhelming. And it would have been easy for her family. She was small, a small woman and incredibly light, and her husband was much bigger. He could have easily, every time she stood up, just spun her around on one leg, even just picked her up, carried her. He could have done that forever. It would have been very easy for him. And we as a team had to we tried all sorts of things. We tried splints, we tried, desensitization. While we were trying all of those things, what we didn't want was that we do these things in therapy, and every night or every time the nurse moves her from bed to chair, she has the reaction, she lifts up her leg, and she learns that she can spin around on one leg. Even worse, use a frame and hop along on a frame. I say even worse, but it's a balance, isn't it? Of course, we want her to move. We want her husband to be able to get her out of the bed and the chair and do these things. Of course, we want that. But in the long term, we also wanted her to be able to walk, and walking requires both legs. So this was just one example, just a story for you that there are times when I am going to be really strict and say, this is spasticity, this is the trigger, and we must work together as a team. And we did, to have her leg down, her foot touching the ground. And it would be, I'm going to say, painful and difficult, and certainly emotionally upsetting for her and for all of us. But we did that, and we did that consistently, probably 3 months worth, where there were signs up all around her bed saying no one was allowed to stand her if her left leg wasn't on the ground. And I'm going to say that 12 weeks later, because we were a team, the spasticity was there. I'm not suggesting that we actually, it was a miracle cure. It wasn't a miracle cure. It was a re-establishing a pattern of both legs on the ground, in standing, both legs on the ground, eventually being able then to lift her foot off the ground and on the ground. Okay, it was a happy story I was telling. I hope that I'm going to now, Bob's raised a hand. See if I can unmute you.
Thank you. Everyone's disappeared. You there?
I'm here and I can hear you.
Excellent. So over that 10, 12, 14 weeks, what you were really doing then is changing the patterns in the brain. You were teaching it to have new habits.
Absolutely.
Okay. So that does actually work. 10, 12 times the habit of something creates a new habit. How quickly then would she have lost that if she didn't continue it? Say she had the flu for 3 weeks and then was back in bed, and 3 weeks and one day she stands on her foot and the same thing happens.
Oh, that's a great question. And I know that she was walking 2 years later.
Okay.
So, yeah.
Right.
But sorry?
Yeah, I'm listening.
No. So that is great question. And that's exactly right. So I'm not going to say, I can't promise that everyone is going to overcome the spasticity. I have to say that first. And of course, because we can't do the experiment twice, I can't know how long. If in that 12 weeks before she had the new motor pattern, the strong message going up and down, there were setbacks, I'm sure. I don't remember them now because I remember it as a very positive thing and everyone in the team working together.
Before the 12-week thing happened, prior to that, did you try to trick the brain or trick the foot? Did you cushion it? Did you pad it? Or was it just the fact that it was so sensitive to something even being near it was the trigger?
Well, that's good. So we had tried already for 3 months not 3 months, maybe 6 weeks. Before we had the full team on board, we had already been trying, in therapy, we've been trying those things without much success. And in the room, she was just being moved without using her left leg. I have to say, at first, for her, it was a brain injury, but at first when there is an incident for the brain does do a shutdown. And hers was a fairly complete shutdown. She had no active movement in that leg. In fact, she had no active movement in that leg when we started the 12-week protocol. We didn't know it would only last for 12 weeks, I'm going to say. We just kept going until she was consistent in being able to put her foot down and having the foot lift off and go back down again. So, and I think by the time, so I'm answering 2 questions. So one was, do I think that after 3 weeks, if she didn't walk on it for 3 weeks, the spasticity would come back? I don't think so, because I think we rewired the brain. If that had happened during that 12 weeks, yes, I think it would have been a problem. And that's why we made the full team approach.
Thanks.
Yeah, no problem. And I think the question might be more along the lines of also worrying that, so I have spasticity now. If I do all of this work to get rid of the spasticity, is it just going to come back and plague me? And that's a very good question. I'm going to say with a stroke and with cerebral palsy and with a brain injury, I think that whatever work we do, I don't expect it to go to, we have to reset and go back to block 1 or whatever it is, because any changes we're making are changes to the rewiring of the local reflexes or the rewiring of the conscious thoughts or even the reducing of fear. And I think reducing the fear of movement, I'm going to say fear will exacerbate spasticity. So reducing the fear is also part of the reducing the spasticity. I don't have such a great message for other conditions, such as MS, where things can change for all sorts of reasons. But even though things can change in MS, within what you have today it is always possible to increase the strength that you have, or it's important to do exercise to maintain the strength that you have. And I think when I get to the end, I'm going to talk about my 5 S's. We want to make sure that for every joint you have enough stretch of your muscle, that you have enough strength of the muscle, that we've worked through the skillful movements for your muscle, that we've looked at spasticity. That's always my 4th S. So although it's the topic of today, it's not the most important thing in the retraining process. But if it's still a problem, then we need to look at other things, which we'll talk about. And sensation, that's my 5 S's that I will look at every time I'm looking at anybody's movement to make sure that we're using the sensations coming back from the skin and the muscles to integrate into the motor pattern. I think that I would really like to have individual conversations with each of you, but let's just stick with this for the moment. I've got to move my mouse back to here and let's watch. Thank you, Mr. M, for this video. We'll come back and watch this again. This is a fantastic demonstration of, even though spasticity is there, and I'm going to demonstrate the spasticity. So to make sure that it's spasticity, not something else, I demonstrate that I can move Mr. B's hand all the way open, or much further than he was opening it. And then when I move it quickly, there's a catch, and the spasticity stopped him from being able to move past that. For Mr. S, the clonus comes in, and I'm going to say this is at the beginning of a session of about 30 minutes. We did all sorts of work, stretching. And at the end of this session, I did the video of this next thing. So the clonus and the spasticity come on when I move his hand. When he's trying to do something which is hard, like standing on one leg, his hand is so relaxed now, it normally comes on, and here you see it there, the clonus will come on. Tribute to the fact that he had done such a good job of stretching it out that it wasn't so, okay, sorry, Miss L. You really have to work hard to see the spasticity when she walks, but clearly there's that clonus. As I stretch it quickly, the reflex kicks in. I'm going to move the soleus now, and I'm stretching it slowly, nothing, just smooth movement, no problem, but move it quickly. So you'd say with her walking, it doesn't make any difference, it doesn't matter, she can walk perfectly well, but have a look at this. So moving fast, the tendon is being stretched quickly, and as soon as the stretch of the tendon happens quickly enough, it triggers her clonus for her, interrupts her running, which lucky for her, she's working on running retraining, as is our friend here. So his right leg moves very easily. And I'm going to say that, well, I'll tell you, there is spasticity in his quads. And for him, I'm not going to work so much on everything I'd work on as well. I look at that when he lifts his arm and walks, I look at that and I am so happy, because I can see his movement has just improved so much. Not by Botox, or hang on, I'll stop this, not by anything complicated. The last fellow who was walking, I will just say it more clearly, he does have spasticity in his calf and in his quads even, which can cause his knee to flick straight. But even while I work on that to get better control in his calf, his quads, work on those spasticity separately, just changing the movement pattern, just stretching out his body so that he's not fixing with normal muscles that are working well, he's using them to hold himself tight to protect himself. Well, block that and his walking improves. So sometimes what we need to do is focus on other things, work on other things, improve the motor retraining of other things. All right, so I kind of want to ask you, I'd like to just, my next question is, can I make it better? Can I make it worse? All right, I'm going to show the video again and just talk a bit more through, and just have a look at this hand. So I think you can see that the finger joint is pulled back on some of his fingers. It's pulled back at the last point, and and on all of his fingers, the spasticity, or let's just say the joint is bent at the middle of his hand. Some of the joints are pulled only at the very end. His thumb bends nicely. So you could spend your time asking, why did he get spasticity in the muscle that opens his hand at this joint? Why did he get it pulling so hard on those end joints that in fact it's pulled the joint? It's one of the joints, the tendon has actually come off where it should be, but all of those end finger joints have been damaged by the spasticity. So there's no going back on the damage that the spasticity has done on some of those joints. there's no explanation really as to why the spasticity in that muscle was so much stronger than the one that joins onto the middle part of his finger, and that the one holding his wrist his hand moves, but now I'm going to say his wrist doesn't move at all. I can't even get that. The spasticity has damaged that quite comprehensively. Why it's this, that, and not the other, I'm not going to answer that. I mean, I can't. But this fellow has worked so hard on maintaining active movement despite spasticity. And a large part of that is practicing moving just within the range that doesn't cause the spasticity. This is what might work now for you if you're thinking about your hand. If you do have a little bit of movement, but moving it quickly causes a spasticity, then the first logic is move it in the range that doesn't cause the spasticity. And the second logic is stretch that muscle out so that the tendon reflex comes on later, so that the tendon reflex, so you have more room of no reflex responses to practice that motor control. In this next case, the stroke, the messages coming down from the brain have not returned. There's not been sufficient return to get motor control into the hand. There is for the shoulder and obviously for his leg. And Mr. S, has done a fantastic job of working really hard on every single opportunity that he's had to get movement to come back. But now, several years down the track, he is continuing to work to maintain the range of movement of every joint in his hand. And when he does get into the clonus, he changes position so that it doesn't continue the reflex arc. For Mr. S, the pain and stiffness of the spasticity is the hardest thing. And so my question, your question to me might straight away be, that might be for you. The issue is the pain being the hardest part. And my discussion would then move on to, of course, stretching and of course, positioning, but then we would move on to medications, even Botox. And perhaps we should move on to that now since it's already been half an hour. I can move to the next slide, I think, if I just press that, yeah. The first question was, can I make it worse? And learned non-use is what I was talking about with my lady who lifted her leg up. She could have learned to not use that leg. Or if your hand moves, but it's just annoying and it doesn't do the right thing, we can learn not to use it, because your hand especially, if you can learn how to brush your teeth with the other hand, you can learn how to eat with one hand, you can drive a car with one hand. The risk of learned non-use on the hand that's affected is quite strong. I know you know that already, but it's, yes, can I make it worse? Yes, learned non-use would be a problem. And that's when you need to talk to the people that you're working with. I've written just clench your fist because when I started physio, people would give a soft ball to the hand because like the hand moves. I mean, initially after a stroke, it's satisfying to watch the hand clench that ball. And it's satisfying to watch it in a little baby too, isn't it? Don't you just love the baby clip, grasping onto your finger? With a baby, I'm not the slightest bit concerned about you overusing that reflex. A baby will work it out. But after a stroke, the motor system is not, it's not a baby's motor system, it's yours. Clenching a fist is good as long as you also open the fist. Clenching the fist is fantastic to strengthen the muscles. And even if your muscles of opening up aren't working, thinking about it, trying it, consciously maintaining that body image in your mind of my hand closes and it opens, then you're not going to make it worse. So the actual hand going into a spastic position, that's not the problem unless your joints are excessively active, unless the spasticity is excessively active in those first phases, especially after a brain injury. When everything else needs to be stabilized, the spasticity in your hand seems to be the least, and it is a low priority in comparison. You can make it worse if it's excessively active, or if there is absolutely no movement and I'm going to say underwhelmingly passive. By that, I just meant you ignore it and you don't stretch it. And yes, that could make it worse. And the third one, which is when I was 16 and I had my aunt, I was worried about over enthusiastically stretching her hand. And I watched people stretch her hand. I asked people to stretch her hand and let me watch it. I asked her when she was able to tell me what it felt like. And I established different ways that would help to stretch her hand. And I know my patients tell me all the time the way that works for them, the best stretching pattern, maybe like that first and then like this. Other people will put their hand like that back down on the bed behind them and then stretch out, or your leg, or whatever it is. I can't say that it's not possible to make it worse, but it's not likely to make it worse if you are being careful and sensitive. And I put this on. This is just a video. So this is my little group of violins. This was supposed to be comedy relief. The part I'm saying is, so when the children are playing, they're not all playing perfectly. In fact, some of them are playing, it's pretty tough to know what they're playing. But doing something slightly wrong, slightly out of tune, slightly out of beat is not the worst thing in the world. And some of these girls were playing just one note at a time. Some of them, okay, I also showed it because I'm very proud of these ones. This was obviously, we all came together for the people in the community it's a Diwali song. But my bigger message is about don't do nothing just because you can't do the perfect thing. These kids are brilliant. Learning the violin, anybody learning the violin is a perfect example of don't stop just because it's not perfect, because it's not going to be perfect first go. So let's go on to this. Spasticity, can I make it better? Absolutely. So in some circumstances, if there is message coming down, both to the messages, to the muscles pulling in and the muscles pulling out, with motor retraining, yes, you can make the spasticity better, in as much as spasticity can be less of a problem for the movement with motor retraining. And I think that's Malcolm Gladwell's book called Outliers, where it's like 10,000 hours of practice so Mozart had 10,000 hours of practice before he wrote his amazing symphonies. Bill Gates, Tiger Woods, they had hours and hours of practice. So hours and hours of appropriate, clever, thoughtful practice of both the muscles that are spastic and the muscles that are the antagonists can improve your spasticity. And that's why you come to us. And that's my passion, is to get you into that position where you can have better movement. And the second point is strengthening the antagonist. So if you have spasticity in this muscle, the opposite muscle is called the antagonist. And so let's strengthen that antagonist. This is where I have to talk about Botox, because that's the point. With Botox, we will poison the spastic muscle, which is the agonist. We'll put a small amount of poison in, which will block the messages going from the very local messages going from the nerves to the muscles. Just block that. The body will regrow nerves around that blockage. So within 12 weeks, everybody, like the muscles, will be able to move again, because our body is so beautifully plastic and we can branch around. And a problem, in this case, the poisoned synapse ending, we can grow around it. And if in that time, while the spastic muscle has been blocked, we are able to strengthen the other muscle to move the joint, then we have a chance of motor retraining. Then we have a chance of maintaining that. And I hope it's not just Bob who's asking this question, other people too. Will that remain? Can we strengthen that antagonist sufficiently to mean that I can then move my hand? I can balance both the muscles. And I'm going to say that that's our goal. That's where we work towards. Can we? Is is not 100% certain. And I'm guessing that some of you, a lot of you have had Botox on one muscle, maybe your calf, with the goal of being able to walk better, with the goal of being able to get your body weight over your foot better, more safely. And we hope to strengthen we hope three things. We hope to strengthen the muscle that is the opposite muscle of the spastic one. We hope to retrain the body to move forward, to rewire, to understand that I can now roll forward on my foot, my ankle, it's not pushing against me, and this is a safe place to be. And now in that safe place, I can train all the other muscles of my leg to take on this position and to balance and to do whatever else is required. So if strengthening the antagonist isn't sufficient, the ankles, the other muscles hasn't moved, isn't getting enough messages down in order to counterbalance the spastic muscle, then can I make it better? Yes, with active versus passive exercises. So if it's possible, for even if those muscles aren't working, for an active, conscious, deliberate movement of my whole body to get the weight over my foot, if I can if I can rewire the pattern to be an active pattern, then yes, that can also counteract the spasticity, so that even if after Botox spasticity comes back, then I have changed my motor pattern and my motor pattern of my ankle, of my hips, of my postural muscles, of my confidence, and reduced my fear of stepping forward. So the classic, you might be in this situation of your foot goes forward, you can walk, but only your foot goes forward, but you can't get the other one past it. And if that's the case, then that's where the motor retraining comes into play. But I know that for some of you, but for some of my patients across the whole time that I've been a physio, spasticity, did I make it better? No, not for everybody and not in every circumstance. And that's where I think that was a way of, that's another story. If you want to talk about how to retrain your hand, then we can talk about that later. I'm just on the point of talking about all the different things that we need to do. So I'm planning to talk now for just another less than 5 minutes, and then open it up for all your questions. And the 5 things that I'm going to talk about are these 5. And if you have a question on any of these 5, now would be a time to raise your hand, because I can see your hand raising. So conservative management is what you've probably already been doing. Conservative management is the motor retraining that you do in the hospital setting, where your arm isn't working properly, but moving a little bit, we put a cup there, you reach for the cup. If it's not reaching perfectly, we change this parameter of that one so that you strengthen the muscles you need, so that you'll be able to. Conservative splinting and stretching is what I did with our Miss S, my lady from that I was talking about with the leg that bends up quickly. We stretched and we splinted, and I have stretched and splinted lots of people over the time. I've even so we did a study where we had people on a tilt table, and every single day for 3 hours they were stretched, but standing up on a table with one ankle stretched 30 degrees and the other one flat. Stretching and splinting is great in the short term. Unfortunately, the research study showed that even after that, all that stretching and splinting, if there wasn't they did that for 3 hours a day it was for 6 weeks in the end. 3 hours a day for 6 weeks, 5 days a week. If there wasn't active movement to help, active movement as part of the motor pattern after that, the benefit of the stretch lasted just 3 weeks. And so stretching and splinting, if we don't have enough active movement, is essential. It's for maintaining your joint and for reducing your pain and whatever else you can tell me how it helps, but won't necessarily remove the spasticity from the system. Oral medications. So my guess is that you've heard of baclofen if you're not already on baclofen. And baclofen with various other medications that are similar, that act on So we can attempt to dampen down all messages going down to your arms or your legs with Valium, all sorts of Valium type medications. Dampening down all of the messages is clearly going to be problematic if you are trying to stand up. It's not problematic, however, if pain is the biggest issue for you. So in that way, the Valium-based medications are appropriate. Baclofen attempts to act to stimulate the opposite of a tendon reflex. And that is also, so baclofen is a very good starting medication to help us cope with spasticity. And it's also appropriate at sometimes to have more baclofen at times when you are really doing a good job with the opposite muscle and you're working well. And sometimes you can have baclofen more in the morning if that's when your spasticity is the most problematic, more after exercise, whatever we can have that. We can have baclofen just as an oral medication. It can be also as a pump placed in your body, and then with the medication going directly into the spinal cord where you need it. So intrathecal baclofen is an option, and it's a very successful one, and I have used that with a variety of patients for a variety of things. Also, not just spasticity, that will also help with other conditions where tightness and hypertonia is the issue. And then I've called it botulinum neurotoxin A because that's what the Botox is what's it called? A brand name. This is, yes, so if you have already been to a clinic, you've already talked to your neurologist about Botox, well, I'm not sure that I'm going to be giving you anything further, but if you're seeing a physio, ask them. Make sure you ask as many questions as you can if Botox is appropriate for you, or if it's appropriate now, but not always. And then there will be a referral for surgery. And there are two types of surgery. One would be the orthopedic surgery. On the hand that you saw in the video, the joints have been damaged by the spasticity. We could have orthopedic surgery to fix those joints into a more useful position. We could, on a foot or an ankle, if the spasticity has damaged the joints of the ankle, we can have surgery to stretch out the calf muscle, for example, so that the ankle stretches back further. We could fuse the ankle, though that's I'm not going to be advocating that anytime soon for most people. Or there's surgery that is in the spinal cord itself to touch the nerves that are responding in a spastic way, to cut those ones, so stop them from activating, leaving intact the spinal nerves that are working perfectly fine. That is certainly not something I'm going to discuss openly or just to a general group on this, because that's very specific and dangerous, but I also have people who have benefited from that. So if that is something that you need to talk about, then talk about that too. Nobody's put their hand up. Is that because I didn't stop talking? If you would like to say something, if you have a question, okay, yeah. Great, Bob, jump in.
Thank you. One clarification, if I may, and one question. The question is to do with the stretching and splinting. So for that 6 weeks, you spent something between, say, 90 and 130 odd hours, and it may or may not work. What else could you have done in that 90 to 120 odd hours that maybe be as effective or less non-effective?
Okay, great question. So that was in a spinal cord injury unit, and the people hadn't left the hospital yet. So allocating 3 hours outside of their therapy was not a problem.
Okay. So
that's your first question. And I'd also like to say I didn't do the study. I was just a physio who was part of it. So it's Lisa Harvey's study. I should have put that in this. And if you were to look up anything on Lisa Harvey and spinal cord injury, and even stretching, she is absolutely amazing. So she is the guru in that. And those were her questions exactly. So your first question was, what could we have done that? Use the time better?
Thank you. The clarification is to do with, I suppose it's more clonus, but for example, if we're going to sneeze, we get a sense that we're going to sneeze and we grab a tissue. If we're going to yawn, we get a sense we're going to yawn and we put a hand over our mouth. And for those poor devils that get migraine, some get itchy eyes and some get tingling fingers. I never know when my legs are going to pulse and cause me to stumble and nearly fall over. I want to know if there's a way I can train my brain to be aware that a hyperflex is about to come and do me a mischief.
Wow. Okay. In this public setting, you don't have to say whether your injury is a spinal cord injury or a stroke.
Neither.
Okay. All right. So I have. All right. What I'm going to say is, I don't know. Okay. I would be very interested. I have talked to people about how to know, like to predict what's going to happen. And people do have sensation of something happening. So once somebody is walking, I do not usually find that the spasticity comes on unpredictably. When somebody's not walking, unpredictable spasticity I see all the time.
Yeah.
That's why my thought was that if it's a focal reflex, like quite a really local reflex, I'm surprised to hear a sudden and uncontrolled movement while unpredictably like that. If your injury is using the spinal reflex arc further up, which is why I'm saying spinal cord injury, that is more unpredictable, and I could imagine that. All right, that's the next question is how do I learn how to predict it?
Mm-hmm.
And my guess is to think about standing in one position and just moving, finding out what angle your foot is, okay, or your knee or whatever it is.
Yeah.
And because I think I said, did I say before on that list, position of your joint is a trigger. So maybe on that step where it did have a hyperreflex and kicked out, maybe that was the step where your ankle was further out to the side, and therefore the particular position was the position that set off that reflex.
So I could actually map that then by just going through those motions.
Absolutely. If you stood on a Wii board and and you can see where the weight distribution is, yep, and or anything. I mean, so that's for example, and then you find out, yes, okay, but that's only a static thing, because what you've said is that it's when you're actively moving that it comes on. But yes. So just before you say anything, so for everyone is different, and where you have where the spasticity comes for you, whatever position it is different for everyone, and that's where you need to like tell me. And sorry, Bob, you have another question?
No, I'm going to back to lower my hand, but thank you, that was great.
Oh, yeah, no problem. It's really nice to talk to you. Okay, and Arthur, I will. So Arthur, I will I'll get Jose and Sonia to talk first. Sorry, I know you had your hand up first, but.
Me? Are you Sonia?
Yes, Sonia.
Okay. Yeah, no, look, I just wanted to say thank you for giving us a bit more of an insight into the whole spasticity area. I just wanted to thank you.
You're welcome. I'm sure that not everything I said was helpful to you, but let's hope that everything was helpful to someone in the whole group.
Yeah, no, it was good.
Okay.
Thanks for that. Thank you.
No problem. Oops. Jose or Josie?
Josie.
Josie.
Josie. I'm from Quebec, Canada.
Okay.
Okay. I have HSP, which is a neurologic. It's neurologic problem.
Yes.
So I believe in reinforcing thinking, like lift your foot, or when I swim, kick your legs. I'm talking to me all the time. But to me, the stretching and moving, but I just feel I do so much, but I don't know if I'm getting anywhere. So is it just normal, or is it?
Oh, I understand. So, yeah.
Is it that, like I heard the gentleman saying he would like to know when his spasm come up. But me, it's just not towards the end of the day. The legs, the legs are very stiff, and So I don't know, is it because I should do more stretching at the end of the day or something like that, or just continue doing?
Yeah, and look, so there's not going to be the perfect answer, but my suggestion to you is exactly that you think about those. Okay, sorry, you said before, which I wanted to come on, you said, do I have to just think about lifting my foot up?
Yeah.
I have to just be more conscious of it. And that is, for me, that third S, that is the retrain the brain, rewiring that pathway. And you can only think about lifting my foot or heel first. You can only think about it so much. It has to become automated. And once it has become automated, then you don't have to worry about it. What I'm going to say is then, like, this is a really hard question of how long is a piece of string, and I think Arthur might actually just agree with me as I'm about to say. But so for you, Josie, I'm going to say, not exercising is definitely not going to help you. So continuing to exercise is the plan. Okay. Exercising more cleverly so that you're exercising or stretching specifically what you need to exercise or stretch is what you need to do, so that you're not spending 3 hours every day doing this. You are, half an hour at that time when your when your walking becomes more difficult. That's the time. That's the time, perhaps, that half an hour would be the most appropriate time. Specifically, what exercises to practice, that will come back down to the specific skills, so that you're more efficient in the movements that you're doing.
Okay.
Having the spasticity addressed is also important. So maybe it is about the medication, maybe it's about the looking into surgery. And then sensation, yes. So just always being aware of, making sure that you are thinking of your body as a whole. You're not, you're including your feet and whatever as part of your whole body image. It's not enough of an answer for you, but I'm going to have to finish.
No, c'est bon. That's good.
Okay. So I'm actually, it is after 1. And Arthur, you have a question, but I'm going to say, and Lee has a question, but actually we have an MS class that needs this to start. So Arthur, I'll talk to you when you come into class next. I mean, sorry, Arthur, you can talk?
Sure, no problem.
Okay. And Lee, did you want to say something? Otherwise, Lee, you can talk.
I just want to thank you for this. It's answered a couple of questions for me. I've had cervical dystonia for about 14 years. And I think one of the hardest things I find is to balance my need for rest. I've got a very physical job as a remedial massage therapist. And I find that I can only rest for about 6 hours at a time. So I'm trying to balance keeping active with getting enough rest. And sometimes I feel like I'm doing a good job and other times not. And I think I probably need to make an appointment and come in and see you, because you sound like you really know what you're talking about.
Well, I'm happy to see you, but actually I know someone else who is specifically works with cervical dystonia who might be more appropriate, but let's talk for sure. Actually, Lee, your finishing words were just beautiful. I couldn't have said it better. The idea that we need to balance rest and
yes,
we need to balance intensity and